Okay, the form has been submitted. Thank
Okay,
you.
Prerana, please, kindly, I am giving you 30 more seconds for it. Kindly complete. Okay, sure. Okay, Prerana Basu, have you submitted? Can I close the link now? Prerana Basu, have you submitted your
Yes.
form?
Prerna, just write in the comment section. We are going late, please.
No,
So,
Shantanda, I haven't got her response right till now. Prerana Basu. Sorry, can't submit, some problem. Okay, okay, you just hold on, you just keep the form with you. I'll look it after later, okay? No problem. If you have completed the form, no problem, we will see it later. I am closing the form right now, Shantanda.
yes, yes, just close it.
Okay. Okay, so the form has been closed, Shantanda.
Okay, okay, fine. Sir is also here. Good evening, sir. Good evening, sir. Welcome. Sir, I think the mic is on off, sir. That's
Yes,
why you're not audible.
right now it's on. A very good evening to all of you.
Yes, sir. Sir, I think you can just increase the voice. Actually, I think sir, it's not very loud.
Yes, can you
Sir,
hear me?
just
Can you hear me?
yes, a bit louder will be.
Bit
I think
louder will
sir.
be better.
Yes,
Just
sir. So
hold
I
on.
think yes, you can just increase the volume of your system, sir. Then it will be fine.
Fine. Good.
হুম না না সার্ভে নেওয়া হচ্ছে একটা আমাদের ওই রিসার্চের জন্য। তো সার্ভেটা আমাকে নিতে হবে না, আমাদের গ্রুপের সার্ভে? হ্যাঁ। হুম। না আমি
No, sir,
আমাদের
you are
গ্রুপের
not audible,
কোঅর্ডিনেটর
sir.
আমি।
Hello, sir. Can you hear me, sir? You are not audible, sir. No, sir, you are not audible, sir.
Hello, can you hear me now?
Yes, sir. Now it's fine. Yes, sir. Now it's fine.
So everything is doing well right now. Okay, fine. We had done the last class. There was a lot of technical glitch. Even the starting of this particular thing, I had a technical glitch right now. Right.
Yes, sir. Now
So
it's fine, sir.
the first thing that I want to tell you, after every lecture is finished, please go through what I have said and do a little bit of study. Take out your books and get to study things, because there are certain things I also expect that you should know, and you should also do some research or takes other inputs from outside, so that you are able to answer the questions legibly. So questions will be set based on that. Anyway, I'll not waste much time because we are already late. I'll try to present.
Yes, sir.
So, welcome everybody to this second session. Now, you have gone through the little preliminaries of trauma, but now we are coming into the one of the main part of this series, that is mandibular trauma. Because this is a very common trauma that we get to see, that you also all will also get to see in your life. Before we understand or go into the details of mandibular trauma, we need to know something. Some concepts are important. And let me tell every one of you, please listen carefully. Let me tell every one of you that most of the lecture in this series will be concept oriented. It is not about just fixing the mandible straight away, jumping into the line of fire. No, first gather the concept. That is what we at MaxFact do, is have the foundations very strong within you. If you have the foundation strong, you will be able to reciprocate it or apply it in your practical life better. This is the goal of this whole series of lectures that I prepared for you all. So we'll start with the mechanism of bone formation, and our whole thing will be directed towards the practical aspects. We'll not go into the very detailed cellular microscopic aspect of everything. That is not needed, but we should know exactly what is going on. So the membranous, there are two types of bone formation. There has been a membranous and endochondral. So if I say if it's membranous or endochondral, I have given a list of frontal bone, parietal bone, nasal bone, maxillary bone, zygoma and mandible. Can anybody of you tell me they belong to which group of the bone formation? Is it membranous or is it endochondral?
Okay, guys, ready?
Please type in.
You're waiting for the answers, please.
Please type in. Nobody?
Yes, sir, the answers are coming. Joybrotho, frontal membranous. Two of them have told membranous, sir.
How many of you agree that it is endochondral ossification?
So,
I say it is endochondral ossification. Am I correct or wrong? Yes or no? You agree? How many of you agree with me?
so is it endochondral ossification? Yes or no? You can write. Mandible, maxilla, endochondral ossification. Answers are coming. Mandible, maxilla, endochondral ossification.
So my question is, out of these two, membranous and endochondral, and I've given a series of a list of bones, most of them belong to which particular membranous? The answer is membranous. That is, the mechanism of bone formation is membranous. Do you know what is membranous bone formation? You know, a particular bone is just formed, the osteoid is directly formed right into the I'll just get a pointer for me. Let's see if it works. Yeah, I hope you can see. Suppose these are the mesenchymal cells, and if these are the mesenchymal cells, bone is directly formed. Ossification directly forms in these areas. They don't need a template. They directly form within these areas. There is the ossification directly forms here. But in case of endochondral ossification, we need a template. They need a template. Endochondral ossification needs a template, but in membranous ones, they never need a template. So that's what I was telling, that there is a direct mineral deposition onto the organic matrix of the mesenchyme of the connective tissue. The minerals are directly deposited into the mesenchyme of the connective tissue. This is very simple. I'm keeping it very simple and straight, just for understanding. I'm not going to the details of the cellular details. Now we come into the endochondral ossification. For any endochondral ossification, it happens usually in the bigger, larger bones. I'm trying to draw some bone. What is this? Probably I've drawn a femur. You agree with me? So if this is the femur, femur is the long bones of the body. Tibia, fibula, femur, all these bones, they are through the endochondral ossification, all the long bones. For this, they need a template. Like, first a cartilaginous template is formed. This is just an overly simplified explanation I'm giving you. A cartilage template is formed, and in that cartilage template, we have a perichondrium. What do we have? We have a perichondrium, which is surrounding this cartilaginous substance of the bone, and within these areas where I'm putting small dots below the perichondrium, there is membranous deposition of bone. There is all membranous deposition of bone. This is what we call it, the endochondral ossification. After all, there is a membranous part which definitely happens, but it happens below the perichondrium. But overall, since it is involved in the cartilage, that is the reason it's called an endochondral ossification. All the long bones. Then very specifically, since we are more concerned of the craniofacial skeleton, keep a note of this. Nasal septum is derived through endochondral ossification. Also, the internal bony components of the nose, the occipital part of the occipital bone, that is part of the skull base, the skull basal part of the occipital bone, they are from the endochondral ossification. Cranial base, sphenoid. What do we have in this cranial base? I write it here. We have sphenoid. Then we have another one that's called temporal bone. Temporal bone has one as a petrous part, and other is the squamous part. So if I say it's a petrous part, so what do you think? Which part? I'm going to tell you one clue. Out of these two, petrous or the squamous, one is through endochondral ossification. Can you name it? Please, someone type. Someone. Very good. It was Jayabrat Sarkar. He answered it very well. Is the squamous? It was the petrous part of the temporal bone that is actually through the endochondral ossification, whereas the squamous part is through the membranous deposition directly, membranous ossification. So this is all about the mechanism of bone formation, and it's very important because lots of confusions come into our mind. Now there are certain points to be noted, and because there are certain confusions arises with these bones. That first thing, all the appositional growth that happens in all the bones, it happens in all the bones. Apposition, that means there is the joining of the bones. Membranous or endochondral origin, irrespective of that, everything will oppose, the bones will oppose and join and fuse together. If, for example, if one skull bone, the temporal bone, is fusing with the sphenoidal bone or parietal bone, and there will be an appositional growth. All proceeds via membranous bone formation. Everyone needs a membranous bone formation. Even in endochondral ossification, I told you, membranous bone formation is very, very important. And that is the basic de facto. And remember, modeling and remodeling is always an ongoing process. After the total growth is completed, you won't be able to differentiate that which was the original bone, because originally the bone, whatever the bone that appeared in the early days, will never be there after years, after the growth has occurred. And even you won't get the, in case of endochondral ossification, you won't even find cartilage. Even the cartilage, the endochondral ossification cartilage will not be found. This is the fact which we should know. So after the skull growth, there is no trace of the initial bony material and also the calcified cartilage in case of endochondral ossification. I mean the second point. Now the question is, I want someone who is very intelligent to answer me this. Does the origin of bone play a significant role in the later repair process? For example, if someone has a fracture or if the bone is remodeling or repairing, does the origin of the bone play a significant role?
Okay, anyone in the comment section can give the answer.
Let me see. This is an intelligent question. Someone has to come up. I want that intelligent guy or the lady or the girl to come up with the answer. Hurry up. We are losing time. No, it does not play any significant role. Research have shown there is no such role. Because why? I told you the answer. That is the original. That is the original bone material. Bony material, whichever is there, it is no more there after the growth happens, or the calcified cartilage, whatever thing, they are never found. So the no traces, and they have now matured into a more mature bone, and so there is no discrimination. It does not play a significant role in the later process of repair, even if it's a fracture. So don't be confused by this. Keep this in mind. This is an up-to-date record which I am telling you. Now, what's the main goal of the function of a craniofacial skeleton? First is protection, as we know. It protects the brain, the eyes, the respiratory pathway like the nose, the sinuses are there, and all the other respiratory pathways are there. And it has a functional component. My God, the functional component is lying so much down. We have just ignored it. Mastication. So this functional component is also a part of the job of this skeleton. Otherwise, we wouldn't have survived. And how does it protect? In what way does it protect? The shell of the cranial wall is a composite structure. It is a various types of structures are there. Especially in the calvaria region, it's a dipole, right? If you go to all the skull bones, the calvarial bones, if you see that there is the outer vault. This is the outer vault. There is a bony substance. There is a intermediate vault, and last the inner vault, to which the dura is very much adherent. So if someone gets a hit on the head, there are chances that the outer vault will fracture, trying to prevent the inner vault. And this is the buffer zone. The intermediate vault is the shock absorbing zone, and so the shock is absorbed and the brain is saved. And another very important thing, the hemispherical design. How come hemispherical design be advantage? For any impact to be at its maximum, the thing should be, this should be 90 degrees. There's a perpendicular. If the skull is slanted, it has a hemispherical design. Suppose the impact is coming from this side, it doesn't strike this particular skull bone at 90 degrees. There is an acute angle, with an acute angle it hits. So the chances of trauma, that is the amount of trauma, is very much reduced. This is an advantage, and that is also we see in aeroplanes. We see the front face of the aeroplane, very pointed. Why? It cuts the air, so that it can cut off the air. That is the more resistance, the less amount of resistance is generated, and the force of impact is less. And the mid face, we see the mid face, right? The maxilla, the orbit, the zygoma, the zygomatic arch, you can say, the temporal process of the zygoma, we can see here. We can see that the frontal process of the zygoma. This is called the frontozygomatic suture. And what is this suture called? Out here? Anybody?
Anybody here? Just reply in the comment section. What is that suture known as?
This suture at this region, what do you call it? Good. Frontomaxillary. Jayabhrata is giving wonderful answer. Very nice to hear from you. I want others also to respond. So I mentioned a thing that's called a cellular structure. What does it mean? It means there is the sinuses. We have the sinuses. There are so many cells. It's like a jail, right? A confined environment. Frontal, spinal, all are there. So all these structures, they act as a buffer areas, and these reinforce the orbitozygomatic frame by this word, what I have written out here, by this thing. What we mean? It is basically these processes: the temporal process of the zygoma, the frontal process of the zygoma, nasomaxillary process of the maxilla, and this process. This is the what is this area? What is this area? This is the buttress, zygomatic buttress. So this is the zygomatic buttress that we are seeing. So these are the main framework of this mid-facial skeleton. They actually absorb the shock, and these cellular areas. And also I forgot to tell you, the lower orbital rim, even the orbital rim is also important, reinforcing object or area. So this is how a mid-face acts as a shock absorber. As I have told you, there's a suture here, there's a suture here, there's a suture here, all these sutures, even the suture out here. So in the questions, please try to, I'll be asking in the examination about the sutures. I'm giving a hint. I'll ask the time of fusion of the sutures, so you should do a little bit of study in the next examination. Now, let's come into the role of mastication, mandible. Muscles are attached to the mandible, and mandible is the moving structure in a whole skeleton. And the forces that are generated actually at the sites of the masticatory musculature. Not only what is this? What is muscle? This is the masseter muscle. Not only the muscle, medial pterygoid, temporalis, lateral pterygoid, all these muscles, all these muscles are taking, they're the forces, they're force generating objects. And even the occlusal plane, they are also giving the force. And these forces, they go and concentrate on the teeth. And in turn, the teeth gives the force to the alveolar bone, and the force is now translated into bones of the mandible and the maxilla. This is how the force is translated while mastication. And do you know the value of force in a mastication? So, what I'll simplify this. Mastication have reactive forces which acts in the occlusal plane, and it has another property, that is, due to the masticatory muscles and the mastication, the anterior portion of the mandible bends caudally, caudally towards the feet, that is downwards. The mandible it's never like this. We don't see the mandible moving like this. We actually have a mandible So this is bending. This bending action, since we are chewing, it generates a lot of force, and the mandible happens to bend down. This is what happens. What I showed you schematically. Now seeing it graphically. Now, so what is the important message that I'm I said all this mastication, giving reactive forces onto the occlusal plane, and it's bending the anterior part of the mandible caudally or downwards. So what does it mean? That is, idea is of this presentation, with everything that I say, we should infer something, we should conclude something. What do we conclude?
Okay.
That most of the tensile component is now created in the alveolar portion of the mandible. So this portion, alveolar portion of the mandible, most component, the tensional forces are created. You have to keep that in mind. This is the message. That is, the alveolar portion of the mandible takes a huge amount of force. In case of the anterior region, that is the incisor region, the force that is generated, that is the maximal force in an average population, has been found is around 200 to 300 Newton. In the premolar areas, it is around 300 to 500 Newtons. And in the molar areas, can you guess how much it can be? It is 500 to 700 Newtons. Wow, great numbers. That means the masticatory muscles are quite powerful enough, and that is lot of forces are generated within the alveolar processes. You have to keep that in mind. That means alveolar process is quite robust in facing these forces. Even if the load of the occlusal plane acts asymmetrically, masticatory musculature is activated in a symmetric fashion. It means, what does it mean? Suppose I'm only considering the masseter or the medial pterygoid muscle out of all the masticatory muscles, just to represent them. This is the medial pterygoid, right? And we have a lateral. Okay, I draw the lateral pterygoid over here. I remove the sphenoid part. Now see, what I mean to say is that these masticatory musculature are activated in a similar fashion. That means both right side and the left side, the muscles will give equal forces, no matter if the occlusal plane or you are trying to deviate your mandible or chewing habits or masticatory habits to right or left, but the forces which are being given from the right side and the left side by these masticatory muscles are same, are symmetric. They are never asymmetrical. But remember, I told you about 200 newtons to 700 newtons the forces, but only a fraction of the maximum biting force is needed. We always do not use 200 newtons. By the way, I want to ask anyone, someone intelligent, you must have heard this word Newton a lot of time. This unit of force, Newton. Can anybody, if you tell me what is how much kg is equal to 1 Newton?
Anyone?
When I say Newton, that is 1 Newton is equal to how many kgs or kilograms? You must have come across the word Newton a lot of times. Forces being said about Newton. This is all about physics, and we are just recapitulating all these concepts that we studied long back. But still, it's good to know.
Okay, so the answers are coming that 9.8.
Samrit Das has given the right answer. That is the right answer. 0.1. Someone gave an equation. I didn't want that equation of how much thousands, but I wanted to know very simple thing. That is 1 Newton is equal to 0.1 kg. So how much is that? To be more simple. 0.1 kg is equal to how many grams? Is it 100 grams? Anybody saying 100 grams? I say 100 grams. Am I right? How many agree with me? Most of the time, lots of people don't agree with me. I'm seeing most of you. Oh yes, thank you, Sambit and Aniket. They have answered it. Yes, at last you have agreed with me.
Yes, sir.
Why it's important? Why I was talking about Newton and why it's important? Why the unit of force is so important? Suppose we have a mandible and there's a fracture at the angle, and we know this is the incisor area and this is the angle. This area is angle. These two areas. So the jaw or the mandible will try to rotate as a resultant of the various forces that are acting on it. And that means we can consider it as a lever. This is a lever on a pivot, right? So this is the leverage point, and this is the force point. Force is acting downward or upward, anywhere. If it's down, going up, we are talking about this. This is the incisor edge, and this is the angle edge. So incisor to angle, if there is a distance is around, let us say average, we are taking 70 millimeter. So we have to calculate this force. Now see what happens. So as we know from our last slides, I told you that incisor region we have the maximum forces. I told you the range was around 200 to 300 newtons, right? So it was around 200 to 300. Now this has, we know so we'll take the maximum, that is 300 newton, and if we take 300 newtons to be the maximum force, so remember in a fracture area, where, for example, the person has having a mandible fracture, the maximum amount of force that he can be using or he might be using will be around this 300 newton in the incisor area, and if it is multiplied by 70, we come into the equation. That is, there is a torque. We have to find the value of the torque. That is the force into the distance. Force into the distance, 300 newton into 70 millimeter, it's around 2000 newton millimeter, which is equal to 21 newton meter. So this is the amount of torque that is actually generated. Right. This is important. Around the torque. Now we know that it is around 20 newton meter torque. So what happens if this is please ignore the slide, something written is scribbled, it was I probably forgot to align these particular things, but I'll explain it what I'm trying to tell you. So we know that it is around 20 Newton meter. And we also know one concept, both sides, bilateral, there is the muscles, when the muscles are contracting, they are symmetrically contracting. There is symmetry. This side, right side and the left side. So we divide this 20 into 2, that means it's around 10 Newton meter torque from this side, 10 Newton meter torque from this side. When we give the maximum force at the incisor region at around 300 Nm. So you have to remember, at least when you are dealing with a mandibular fracture at the angle, you have to give a plate or fixation which should be good enough to resist this 20 Nm. It should be good enough to resist this 20 Nm. This is very, very important thing to keep in mind. So this is the concept. What did we learn? We learned that for successful reduction of fracture management in mandible, we need to take care of the fact that at least 20 Newton meter torque should be restrained by the whatever the thing we apply. We might be putting an ORIF, osteosynthetic plate, or whatever screws, whatever we put, whatever the treatment we do, it should be directed with the thought that it has to resist this amount of force. Is it clear? Well, it can be boring at times, to have a webinar going long, but I'm trying my level best to make things easier for you. So this is the area, you see the red point, the red dot is the area of the maximum 10 Newton meter. And this plate, what I told you, should resist this 10 Newton meter force. At least it should have this capability, at least. And if we consider the molar activities, then the value will also increase, because in that case, in case of molars, we know its maximum was around 700 newtons in the molar area. So in this case, 700 into 7, that is, we'll have near about 50 Newton meter torque. So one side will be having a 25 Newton meter torque. That is quite great. So on cooperative patient who is having a fracture, and you haven't kept this mind that you might give a maximum torque of 25 Newton meter, then you are going to fail in that case. You will not be able to manage that case. You will come with complication. You will come with malalignment. You will come with non-union to you. So this concept is important. So what did we learn? We learned that we must understand the forces that are being generated on the mandible. I'm just revising. The alveolar areas, the forces are concentrating in the alveolus, mandibular alveolar areas, and we know the incisor area is around 200 to 300, and the premolar area. Can anybody, if you tell me what is the force in the premolar area? I'm keeping it blank.
Anyone?
And the molar area, it's around 500 Newton to 700 Newton. So I want someone to fill up this blank.
Okay, anyone please write in the comment section the force which is present in the premolar area.
It should be interactive. Everyone should be interacting. I want people to interact.
Okay, sir, answers are coming 300 to 500.
That's who gave the answer? 300 to 500.
It's by Ankit and
Joshmita Mandal, I can see.
yes, Ankit Pal, Joshmita Mandal.
Ankit Pal, that's good. This is the answer. Very good. You're attentive. If you're attentive, you'll learn something out of this particular session. It will be little lengthy, but still you'll learn something very effective, because what I'm concentrating is the concept. Most of the mandible fractures and all the facial fractures. There are set format. Come with the mandible is a U-shaped bone, and it has this, and there are the IMF plates and everything. And the seminar is finished, and the concept nobody understands. My objective is to make you understand the concepts, the greater inner meaning. So if you have the foundations strong, you can deal situations better. Now we'll go into the biological reactions to bone healing. What is the idea of repair or any healing? It is a bone healing. That is, it is trying to restore the original integrity of the bone, right? That is the main goal. But there is the biological goal. But we have a clinical goal. Our goal, clinically, our goal is to see that whether bony structure can resume to their fullest function. That is our goal. For example, there's a fracture and you see the full function has been achieved by that bone. The no sooner that thing happens, you need not see whether at the microscopic level things are in the total perfect order or not. No, you do not say. That is not the clinical goal. That is the microscopic level. Because the modeling, remodeling will take place, and it will take place sometimes 6 months to 1 year, 1.5 years, sometimes 2 years. So, first thing is very important. I again repeat that we have to make the bone resume its full function. That is the main target. And the microscopic level, we are not bothered. We give a damn for the surgical part. But what happens? The biologic healing. For any biologic healing to happen, we need cells. Don't you think so? We definitely need cells. And if the cells functions properly, there are a lot of cells. There are a lot of cells which functions very properly, which actually are needed into the site of fracture. For example, if there is a fracture area out here, so we need cells, reparative cells. These are all reparative cells. There are also signaling cells. There are also cytokines, all inflammatory cells. They all are needed for the repair. And for that we need the function. We need that we need number of cells should be reaching there, and they must function properly. And these cells, at various times and various phases of the healing process, various different types of cells are needed, we know. But for that, what do we need? The last lecture I have written, the answer is so beautifully sitting quietly yet down. Sufficient blood supply is necessary for that. If you want cells to reach a fracture area or site, so you must think that blood supply to that area should be adequate. That is the main goal for any fracture healing or any sort of healing. So this is what I was telling you. Cells have to reach the site of repair, and it should get adequate nutrition, and it should reach the site of repair. For all these things, you need the sufficient blood supply. And this is how is it possible? We need a sufficient blood supply, because for them to reach that area, cells need blood vessels, and to get nutrition, obviously it needs bloods, because all cells derive its nutrition from the blood. So that is the biologic goal of healing process. Now, when we are assessing clinically whether a fracture is healing properly or not, the rule of optimum and balance is very important. We cannot only concentrate on mechanical events. That cannot be always true. We also have to look after the biological event. Last time, just a few moments back, I told you we are going to see whether the function is okay. But if the biological reactions are too down, they are not good enough, do you think there will be successful healing no matter we have restored the function? No. Later on, there will be secondary formation of calluses will form, and there can be formation of cartilaginous thing, and there can be non-union. So for both these things, both these events are very important. So and they each of the event they're interdependent. Biological reactions will definitely have an effect on the mechanical environment, and also and vice versa. Mechanical environment will always have some kind of effect in the biological reactions. They are actually interdependent species components, and these two components should work in harmony. If they try to work in disharmony, then healing will not be successful. Healing will not be possible. May not be possible. So we come to the fracture healing clinical concept. Initially, what happens? I'm not going to the very detailed things of fracture healing, but I'm telling you, highlighting you. Most of you have learned fracture healing. Most of you already know what is fracture healing. But in spite of that, I'm telling you these things because these are some pretty important things, very petty things, which are very important, and you should have it in your mind. So whenever there's a fracture, there's a disruption of blood supply. It's basically the periosteal strip. And one of the main reason is the periosteal strip, this periosteal strip. And the disruption of blood supply is also related to other things like the soft tissue around this whole area. If I take the soft tissue around this whole area, might be inflamed. There may be inflammatory things, and as a result, there will be disrupted blood supply. If there can be major blood vessels which can be damaged. The blood vessels can be damaged. Major blood vessels that can also compromise the blood supply. But why did I mention periosteum? Someone.
Okay.
But why did I mention periosteum in the blood supply? Why was it important for me? Was it necessary for me to tell that? How many of you think that I said it unnecessarily?
Please write in the comment section.
I think because periosteum is very rich in blood supply. Very good. Jabrato gave a beautiful answer. That is a very intelligent thing. Thank you, Jabrato. Because periosteum is actually the source of blood supply. It's a major blood supply on the periphery of the bone. If that is also stripped, then that means there's a disrupted blood supply. Definitely happens. So that's very important. And after this, if you go for a surgery, you have an additional trauma and there is another diminished blood supply. So whatever, even if you're doing a surgery, you're actually disturbing the blood supply. So in a fracture area is very much well used to the concept that there is diminished blood supply. Every fracture area knows that thing. So due to this disturbed blood supply, there will be a internal surface remodeling. Two types. The internal part of the bone will remodel and the surface part will remodel. These two remodeling is important. They need to be. Then at the end of the first week, there are many stages of fracture healing. Actually, I'm summarizing. The objective is one has to think that internal area is healing or repairing, and another part you have to think that the surface is repairing. The two components are repair. Internal part of there's a medullary part of the bone and the surface. So by the end of the first week, new bone is formed in the periosteal region. The subperiosteal region. There is a formation of the new bone. It takes at least 7 days to form. So the whole process which I was telling you, the mechanics and the biology, they both are important in this whole process. Keep this in mind. Why? I'll justify that, and that we all will justify that after some time, and we all will be able to justify. Just sit back and listen carefully. Now, when you come into tissues, that the tissues, every tissue is subjected to a lot of shear and stress, and based on that, we have the three important tissues that we are dealing in fractures: the connective tissue, cartilage, and bone. This is what their tolerance level is. Connective tissue is very tolerant. Cartilage 10 to 15, only 10 to 15%. Whereas bone, it's just 2%. It's too less. That means the a bone cannot tolerate much amount of shear. This is to be kept in mind. It's like glass. You hit a glass, it's small stroke, it might fracture. So it cannot take deformation very much. So brass tends to break. This is a classical thing. I hope I don't know whether I should say to you. It would have been better if you would have set front to front. I think I would have told asked someone of you to say something or enlighten us with this. This is a very classical particular process of fracture healing. Says the hematoma stage of hematoma formation. I'll not go into the details. Just for a recap, because we are just orienting ourselves for the mandibular fracture. There's hematoma, then there will be inflammatory cells. They will come. Okay, I'll try my drawing skills in front of you. This is a cell I've drawn. This whole thing. What cell is this? What do you guess? Let me see how many of you recognize. Aniket told me neutrophil.
George brother, PMN.
Yes.
Anyone else? Second year?
Nuclear neutrophil.
First year and second years must come up with this answer.
Yes, this is very important. The first year, second year should come up with this. This is the polymorphonuclear neutrophils. This is the hematoma is formed. Then there are inflammations are taking place. Then there is the formation of the soft callus. Then there is the hard callus. And remember, this point is very important. Most of the people they confuse this. Woven bone, hard callus is also called a woven bone. Most of the time, in most of the books, you'll see woven bone is being referred. What do you mean by woven bone? This is actually the hard callus, not the soft callus. This is important. Then we have the last, where the bone keeps on remodeling. Remodeling is a continuous process. To be continued, somewhat like that. Now, I'll go to the thing that's called a direct primary bone union, which is actually very rare. It is very, very difficult to get a direct primary bone union. No surgeon will ever do that or will ever be able to do it, because direct primary, at least as of today, I don't know in the future whether that will be possible or not, but as of now, direct primary bone union is not possible. And it is only possible naturally if there is a minimal deformation. There is no deformation, slight. People sometimes will say, I've gone to the doctor. The doctor told me that I have a small crack in my hand or in my leg. I got hurt. They use the word crack. These kind of, that means the gap is so much intense, that is so thin, that means there can be the direct working of the healing mechanism of the bone formation. That means the osteoclasts drill their canals across the immobilized and contact zone. Then the osteons will form. I'll give an example. I'll try to simplify it with this very horrible and simple diagram. This is the end of a fracture fragment. This is the end of the fracture fragment. Initially, these are the osteoclasts. But where from the osteoclasts they come?
Anyone, please? The webinar is for all. Why only Joybrot and few just people are replying? What about others? Second years, please respond. I hope your pathology in the pathology section, you have the bone healing is being covered.
Sorry, I lost a little bit of network. You can. Am I audible?
Yes, sir. You are audible, sir. Yes, sir.
Fine, thank you. So, how do these osteoclasts? From where do they come? I'll just.
Okay, please.
Try. If this is the one of the fracture end, there's a fracture. The osteoclast, they happen to start working here. This is the osteoclast. And where from do the osteoclasts come? If I take a cross section of this, and we see there are laminated bones, and there are certain osteoblasts or osteocytes which are present in the lab, in certain lacunae, and these, will get stimulated and they will convert themselves into osteoclast OCs. There is an important protein involved, rank L. I'll not go into the detail of this because it is beyond the scope of this discussion, because we will get lost in all these microscopic details. Anyway, this rank L protein, ligand protein, is now responsible for converting the osteoblast to osteoclast. What they will do, they will demineralize the bone. They'll remove all the calcium things. So as a result, what will happen? There will be the formation of, because the fracture end is rough, they are necrotic. Why? Because whenever there is a fracture, please see in the upper screen, whenever there is a fracture, this zone, the initial primary zone, is actually devoid. What we are saying is devoid of blood supply. There is no blood supply. So there is actually no blood supply. So this is a very necrotic zone. That is, this is devoid of blood supply. The cells are, are breaking down, are become necrotic, and so these osteoclasts now have to remodel this initially, primarily, and after they remodel it, these osteoclasts will again convert into osteoblast, which will again deposit the bone, and this process goes on, and gradually this cone expand into the other part of the fragment, and as a result the bone deposition takes place. This is called a cutting cone, but I am not going to details of the cutting cone because I am not very much interested to talk about all these things, because it will take, we need a lot of time for that. So idea is this osteoclastic activity and osteoblastic activity, they will directly, if there is a very little contact area, what do you think, if this is a fracture and this is another fracture, which has a chance of better healing, A or B? Yes, right. I am only seeing Aniket is only typing and Jayabrata is typing. What about others? This was an easy question. Yeah, it's B, because the junction is too small, too less. Because what happens if if the distance is too less? What happens? Some of the bones, they happen to be in contact with each other, and it is through this contact, the bone deposition, the movement of the osteoblastic and osteoclastic activity becomes easier, and so the union becomes much better. But if it is far away and there is no contact between that, there's nothing. It's like the person is coming and he will finally fall out here. It will coming fall flat. So the person will never be able to reach here. That is the objective. And that is what primary healing happens, that it happens only in areas when the minimal distance. But practically it's not possible for us in a surgical scenario. So this is what I was trying to explain you. Smaller gap areas when mobilized with neighboring constant zones still permit then direct laminar ossification into the gap. That means there is a directly ossification into the gap. So I told you something is contact and there is a direct ossification from here to here or from here to here. For example, if the bone is contacting here, there can direct ossification will. But if what happens in a larger gap? In the larger gap, what happens? There are smaller compartments because this person, in a very simple way, is trying to throw stones to fill up the gap, and then you will be trying to make small big stones like thing, and actually these are basically small spaces that the osteons are being produced. And now when it is full, now this person can now hop and go to the other fragment. That is possible. Initially it will form the small globular compartments, then gradually in the secondary process, in the second step, this will be filled by laminar bone. This will be filled by osteons. So osteons will come up and the laminar bone will be forming. That means it will strengthening later. So this is what happens in larger gap areas. I hope you have understood what I am trying to say by this slide. If there is too much of a movement of the hand, what happens? There is strain. Do you think when there is a movement, too much of movement of the fracture segments, do you think it will heal very well? I want others to answer at least yes or no. This is an easy question. Except Sambit and Jabruto. Others, please participate. Aniket. Okay. That's good. So that is if there is a lot of strain, the fracture will not heal. That is the reason there is a plastering. The people plaster their hands with a cast. So ossification. Why? What will happen? The ossification will not be possible. Now this, remember, this is very important. This is something which you all should know. The tissue differentiation cascade. Initially, for example, if the fragment is moving or if there is lot of movement, then initially there is a formation of granulation tissue. A granulation tissue will form. Do you think granulation tissue is very tough structure? No, it is not a tough structure. Then the connective tissue will form. Do you think connective tissue is little bit a tough structure? Not very much, but at least greater than granulation tissue. Then the connective tissue converts into fibrocartilage. Do you think fibrocartilage is tougher than connective tissue? Yes, it is tougher than fibro. Then we see then it will convert into the mineralized cartilage. Which is more tougher? Mineralized cartilage is more tougher. And then after the mineral cartilage, the woven bone is formed, which is more tougher. And the woven bone is converted into compact bone, which is also the toughest. That means this is a very protective mechanism. See the wonderful mechanism the Almighty Lord has made. That is, the granulation tissue, which is quite soft, actually it was preparing the bed to become stiffer so that the further granulation tissue can convert into connective tissue. And those in turn can convert into fibrocartilage, then in turn mineral cartilage, woven bone, compact bone. That is the softest to the hardest. This is a journey. This process has to go such a long process: granulation tissue, connective tissue, fibrocartilage, mineral cartilage, woven bone, and compact bone. So you can see there's a gradual increase in strength. I've written it out here, and stiffness in these tissues. At the time the tolerance of strain is reduced. At the same time, the tolerance of strain, even since the body is having strain at that moment, the time for tolerance, the same time is reduced. The strain is reduced because it's getting harder. That means it brings a gradual reduction of motion. I don't know how to mop it, but anyway, gradual reduction of motion. So the interfragmentary strain is very much reduced. This permits the connective tissue always formed. So you might be wondering, today we have the thing about mandible fracture. Why I'm not saying something about mandible fracture? Because these concepts are very important before we plunge into direct fractures. Because from the next onwards, when we talk about mid-facial fractures or the upper part fractures, these concepts are clear. You will be able to understand any fracture management. These are very important. So this slide says a lot. When I say that after fracture, then the implant is needed to be removed. Mandible, you can jolly well remove an implant within 4 to 6 months. In TBI, 1.5 years, and femur, this is the longest and the strongest bone in the body. You cannot remove it until 2 years because it needs so much stabilization. Whereas the least is in the mid-facial skeleton, in the maxillary bones and the mid-facial. It's around 1 month, very near about that. That is the advantage of the mid-facial skeletons. They heal very faster. And why they heal? Because they are thin and they have a bone marrow, and which is well supplied with blood. It's very cancellous bone, and so whenever there is a cancellous bone, when I say it's cancellous bone, it means that there is good amount of blood supply. Now these are the potential complications of fracture healing, and these complications: infections, refracture, delayed healing, non-union, implant failure, and implant loosening. Why they happen? Because the causative factor, that is, we use implants, and second factor is also called the general phenomena factor. If there is a disruption in the general phenomena of the fracture healing, then these complications occur. This is very important. Refracture in the cranio-maxillofacial area does not occur without adequate trauma. So this is very important in case of forensics. If someone comes with the secondary, again a trauma to the face, telling you and challenging you that a refracture has happened naturally without any complications, then the person is telling a lie. Remember it. It has to happen. Adequate trauma is needed. Now, we will be seeing this thing written note in so many things, because I want you to note down certain things. In if any fracture, the aerobic and the anaerobic bacteria are there. In case of mandibular fractures or facial fractures, these two species of anaerobic species are very Aspergillus and Actinomyces. They're very dominant species. So you must think, when you're giving antibiotics, think about these species, that at least they should cover these species. And what is the cause of infection? When the soft tissue that is surrounding the fracture, they are severely damaged, and there is a poor perfusion into that area, and so that the cells are not able to reach in that area. That is, polymorphonuclear neutrophils are not able to reach. Macrophages are not able to reach there. So what happens? infection will grow. But remember, this is a scenario that you will see most of the time in your life, that someone might come to you with a plate, with an implant seated in the mandible, and they're exposed. But remember, even if the implant is exposed, if there is exposure of the implant to the skin or in the oral cavity, it does not mean infection. So don't straight away start antibiotics by saying, oh, the plate is exposed and so I start away antibiotics. No, never do that. So why are there delays in healing? When we say that, when the union takes longer than the expected duration. So in the mid phase, more than if it takes 4 to 6 weeks, we know there is some issue. So that is the reason that timeline is very important to know. So this concept is, for the mid phase, we must keep in mind, if there is a delayed healing more than 4 to 6 weeks, then you can think that there is some complication. And for the mandible, it should heal primarily within 2 weeks. And if it doesn't, that means there is some issue. So you need to troubleshoot. Remember, when there is non-union, suppose you're operated on a patient and the patient comes with a non-union, never try to resect that patient. You can operate, you can put a plate, but do not resect that. Because tissue in a non-union represents only an early stage of tissue differentiation. Because you are, why? I'll explain. Suppose there's a bone plate, you have put a plate and this tissue is not healing. Tissue is not healing, what does it mean? Because we saw there was a granulation phase, then there was a mesenchymal phase, then we had some kind of mineral deposition. That is the way the order happens in a moving fragment. So if it is not healing, that means there might be an infection, there's some inflammatory things has happened, and the body is trying, or maybe the fragment is too much mobile. So the body will try to follow that step. So it means that non-union means the early stage of tissue differentiation. If this is not clear, I can repeat again. Keep this in mind. If there is non-union, it means there is early stage of tissue differentiation. That means the tissue, I'm going back, trying to find out the slide. Yes, this is the slide we are talking. We said the granulation tissue, different. Somehow, maybe in that only the fibrocartilage has formed, and it is now not been able to go into the mineralized cartilage phase, then open bone, then compact bone. So the whole healing process is stuck out here. Why? Because due to of interfragmentary movement, there is too much of movement. So what do you infer? So what is the conclusion? That the fracture fragment is somewhere here. That means the healing process is getting a little slow. I'll come back to the slide again. It means the early stage of it. That means the plate that you have put, it is an inadequate plate. It is not a good plate, or it is the not good profile plate, or the necessary things that necessary in your profile. When your profile means the thickness of the plate or the size of the length of the plate. So you need to just change the plate. Do not try to resect it again or refracture it. It won't help you, because the healing has already advanced. And why this has happened? Because it's due to the excessive strain. It inhibits myelination of the moving fracture gap. So what is the solution? You have to use stiffer plates, more hard plates like Recon plates. Now, this is very important. Don't screw up the screws. Usually most of the time screws, they become very loose. And there can be two type of thing: the monocortical screws and the bicortical screws. You can keep a screenshot of this. These are for practical, theoretical purpose. You can prepare it for the examination. I'll not go for the lot details of this. But just I'll just go hover over it. There's insufficient number of screws. If you put insufficient number of screws, those kind of delayed healing can take place. Inappropriate placement of the screws. You have not put the screws in the proper order or proper places. Undue functional loading, you put on the screw. Inadvertent stripping of the screws. There's so many things that can happen within a screw. So since now we are careful that we are not going to screw up with the screws, and we'll be very careful about the screws now indicated for operative treatment of fractures. Now we have to know. Goal of modern bone surgery is rapid recovery from function. It is all about the form. In the craniofacial thing, form is very important, because if you brought the function of the mandible and you made it in a look so ugly, you face the patient is going to take a danda and give you a danda. The goal is optimal stability, not maximal stability. And we should be conservative for closed and simple fracture, and we can use intermaxillary fixation. I hope it's intermaxillary fixation. You all know. Maybe the first year, the second year may not be knowing it. Later on, but keep this in mind. This is intermaxillary fixation. Just keep a screenshot of this. That is, when we need internal fixation, we need internal fixation in these cases. I'll not go into detail because we're running out of time. So keep a screenshot of this. But in case of polytrauma patient, even if the fracture is small, try to intervene early, because whenever there is a fracture, there are in case of polytrauma patient, the polytrauma patient is already having so many trauma, and the perfusion is too much less, and obviously chances of precipitation of infection is very high. So you should act very fast. So do not wait. Some people they think, okay, I'll wait for the swelling to subside, then I'll do it. But that is not the goal. Remember, keep this in mind. Swelling should not be a reason for delayed treatment of facial fractures. This last statement is very important, because the many clinicians will debate with you. No, you should not touch a fracture case until the swellings have subsided. No, in a polytrauma patient, no, this rule doesn't apply, because you need to reduce the fracture so that infection becomes very less. Now, so this is the goal. This is the main idea. Adequate stability is the safest protection against infection, more important than antibiotics. So stability is more important. That is the very important. If you have good stable fracture, plating of the fractures are quite stable, your outcome will always be good. Not going to this. Let's skip some of the slides, because we have Dr. Chetri to talk. Now this is important. The general goals of the operative treatment is early anatomical reduction of the fracture fragments, then maintaining their position after its reduction, and guaranteeing union in desired position. That is, everywhere we're going to see that we need to have a very stable fragment. We don't want a very moving fragment. Too much movement in a fragment is always deleterious. So early reconstruction of the normal anatomy is very important, because it will give us the optimal function and bring the best aesthetics. Know the term fatigue failure. I'll not go into this. sometimes when later when we'll have a live class in front of when I have in that time I'll be explaining other things which I'll be skipping in this session. Now we come to the implant materials. Stainless steel, titanium and resorbable materials are used. Stainless steel, iron, chromium, nickel and molybdenum is the main content, but it is no more used nowadays. But there is a standard, remember the 316L. This is the standard of the, because it is a stainless steel, it's an alloy, right? There are there are 2 grades of carbon contents are there and 4 grades of cold war. They are graded. I mean, from an annealed one is very soft, and the hard ones are extra hard. And what do? Their actual advantage of them is that their corrosion resistance is fair, not very. I would say it's excellent, but fair and more or less comfortable. At least for 1 or 2 years, it can do jolly well. But after 3 years, it might not, because the outer layer of the steel, they might corrode. If the corrosion happens in the inner things like iron, chromium, nickel, molybdenum, they're exposed to the body, and it is known. Remember, chromium, 20% of the population are allergic to this chromium. So those people might face problem. We might face problem. This is exactly what stainless steel is all about. In very short. And now we come to titanium. Pure titanium contains titanium and oxygen, and this is the plates. This is the main material that we use. Grades 1 to 4, based on the strength and stability and ductility. Now, principles of stabilization. We go for splinting. This is one method. We make a cast, we cast splint, and we place it in the patient's mouth, and we reduce the fracture. And this is usually done in pediatric populations. But in splinting, you cannot actually abolish fracture mobility. There will be mobility, but we are helpless. In children, this is the children are growing in the growth phase. We will always try not to put plates or implants, and also due to a phenomena that's called drift phenomena. Remember, you do some amount of research on drift phenomena. I might ask question next time. This is how it looks. A splint. This is. Can anyone tell me what splint is this? What is the name of the splint?
Can anyone? From the final years?
This is a gunning splint. There's a fracture, you make the splint out here, and then you fix it in this way. I'm going a little fast because there's nothing to do with splint, nothing much, because it's very easy. And this is actually, these splints are internal splint, and what I'm saying is the external splints. Internal splints actually are better than the external splint. So when it comes to splinting, always go for internal splints. Now, when you come to bone plates, we use a system that's called compression. This is a bone plate, and these are called the compression plates. Compression plates, what happens? These are specially designed plates. You should listen carefully for those who don't know it. It actually is a path. You can see this here. It comes like this, goes like this. It actually is a path. So what happens? Suppose you are screwing it down. When you swirl it down, this thing goes inside, and as a result, the pressure is created out here, and the bone fragments are squeezed very tightly. These are called the compression plates, or the compression with the screws. Actually, it's all about the plate property. This is the mechanism. You can see graphically. The plate is there, fracture. You put the compression plate like this. As you compress it, the fracture tries to unite. The compression is usually done with lax screw. This is a specialized screw. It is used for fracture fixation of bone grafts. This is how a lax screw is used. It's used actually whenever you want to use a lax screw. It should cross the fracture in a perpendicular plane. This is the importance of lax screw. And another important thing is this. This is called the gliding hole. This initial area. This will be little bit thicker than the thread holes. Why? Because you need to bring this fragment, compress this fragment towards this side. This has to glide in easily, and in this compact bone, it is going to catch up. And when you tighten it, what happens? It is going to pull up this fragment. This is the advantage of the lax screw. In this case, there is no gliding hole. Since there is no gliding hole, this process will be a failure. It is very much used in sagittal split osteotomy, in orthognathic surgery, and also in oblique fractures. I will not go into the details of the screws. There is another use of a lax screw. You can use it in this way, but when you are using in a combination of a DCP, that is with the compression plate only. I will not go into the structure of screws. You can get to see the structure of screws later on. This is the armamentarium, but I'll go into the manual practice and I'll deal it very simply. You just take a screenshot. These are basically the basic management principle, and it's very easy, and you have to keep this thing in mind. Yeah, I'll now come up with a simple midline fracture. You can either put a bone, there are mini plates, you can put a mini plate in the midline, or you can put a compression plate, DCP. This DCP full form is dynamic compression plate. Dynamic compression plate. Another way is to do, you can do mini plates. These are called mini plates. The first mini plate will be monocorticular, and the lower mini plate, the top one will be monocortical, which I have seen, which is shown out here, and the lower one will be the bicortical. That means it should perforate both the cortex, from the buccal cortex to the lingual cortex. We can also use a lax screw like this, but be careful on this area, because if you go very deep, you might injure. Suppose there is a canine root out here, you might injure that canine root. So you have to be a little bit superficial on the cortex. But in this case, you can go deep. This part, you have to drill a hole out here, and you go in the horizontal direction. And what is the size of the lax screw? It is 2.4 lax screw size. Then we can have a situation, we can have a triangular bump out here, we can see. In this case, now see, we have put a universal fracture plate. Over here there are mini plate, one mini plate is there. Over here we are using a universal fracture plate. So this one is just holding it. This one is just holding it. But this one is just working as a tension band. Just holding the bones together, this one. And this is the main plate that is holding the main load. You should understand this concept. Now, a comminuted fracture can be reconstructed 2.4 recon plate. These are just direct formulas. Also, for this thing, you need to have splinted the teeth. Can you see? You splinted the teeth. Maybe with wires, maybe with the arch bar, whatever. It's called load bearing osteosynthesis, because this whole plate, when we put recon plate, we only put this is very important. Load bearing, whenever we need that the implant has to take the load fully, we use the load bearing osteosynthesis. And this is another technique. It's very easy. In the parasymphysis, put two plates, mini plates. or you can put a DCP plate instead of this. You can put a DCP plate out here. Over here, the diagram is showing a mini plate. You can put two mini plates, or you can treat a DCP, dynamic compression plate. You can put a universal fracture plates. This, see the plate pattern. This is called a universal fracture plate. This is another pattern of repair. Remember, these are very important. These are actually direct, clear ways. You can use lag screw. Suppose there is a triangular component, you can use a lag screw, and somewhere it is split sagittally, so you can put 3 lag screws to fix it. This is another component. Every component, because you'll get these situations, very important. Another component, there is a triangular area, and we put a bicortical screw. And there is a lag screw here. This is very important. Can you see? Lag screw. We have put a lag screw. At first, we have put a tension band here by an arch bar. Then we need to put a lag screw first. Don't put these screws earlier. First, apply the lag screw over the plate. Then put these screws. This is very important. This is another case of this structure is called basal triangle. Okay, it's called a basal triangle. This is very important. You'll get to these kind of fractures, see a lot of times. You know, there's a fracture, some kind of basal triangle is forming down the Manna. So in which we have the universal is a fracture plate, one combination with this and with a mini plate. This is another combination. But over here, only in the basal triangle part, we see only one screw being attached. This is a mini plate. It's body fracture. We can see a lot of comminuted fragments. In this, what has been done? One plate, one mini plate is here. Another mini plate is here. That is initially the role of this mini plate is primary fixing the fragment. Just use the mini plates just to fix the fragment. They will not bear the load. They will only hold the fragments. And put the recon plate, because this is the main plate that is going to bear the load. Bear the load. Remember, other bigger plates, as I showed you, PCP or whatever, they don't bear the load. They actually share the load. And this is another. This now we come into the angle of the fracture. Fracture angle. Can anybody tell me what is this plating called? There's a name.
Anyone, guys? Can you just tell me? The comment section.
Because the plate is twisted like a helicopter blade. See, the twist is somewhere here. The twist is somewhere there. So since the plate is twisted, it looks like a helicopter blade. So helicopter plating, there is only one plate, 6-hole plate is given in this area. Three screws on this side and 3 screws on the superior side. Now this also can be done. You can put this helicopter plate out here, and you can put on the superior border, and in the inferior border you can put another mini plate. This reduction is also possible. Now one thing can be very confusing. So which one to do? It depends on what kind of patients you are dealing with, what is the structure of the skeleton, how much force you think the patient will be giving. All this assessment should be done clinically, and your intuition and your experience will tell you the answer. But as a guideline, these are the possible ways you can reduce a fracture. Another way, we put a DCP plate here and another mini plate in a horizontal. This is not a helicopter one. Remember, this is not a helicopter plating. Helicopter plating happens along the retromolar area going up. the anterior border of the mandible, but it is on the lateral border of the superior edge of the mandible, angle of the mandible. So you put a mini plate out here and you have to DCP out here. DCP compresses the bone and fix it hard. But never put a DCP plate in a comminuted fracture. Remember the thumb rule: never put a DCP plate over a comminuted fracture. In case of very simple fracture, you can put a single kind of lag screw. Now, when there is dislocation, earlier ones whichever I told you, there is no minimal dislocation, that's fine. But when there is dislocation and the fracture is well dislocated, in those cases you have to you should use more stronger plating system. You can use a 4-hole mini plate here. Remember, mind the holes. How many holes are there? And this will act as a tension band, bringing the bones together. And this is the main universal fracture plate which can be used. So we talked about DCP.
Hello, sir. Excuse me.
Yes.
There is a question in the comment section that in the helicopter plating, sir, are the removal of impacted or unerupted third molar is required?
Unerupted third molar is not required. This is a good question. Whosoever this more, sometimes there is a dilemma whether we should extract a third molar tooth. Try not to extract a third molar tooth. Try. Why? First reason, it will give you the guidance for reduction. If the third molar tooth is there, you can it can work as a guidance, even if the fracture line is passing through it. First. Second, in case if you have to remove, if you feel now okay, you need to remove third molar tooth. First, do the fixation. First, fix the mandible. Then extract the third molar. Third rule: do not do osteotomy. If you have to do osteotomy in case of the extraction of the third molar, please do not do that extraction, because in doing that osteotomy, you are going to lose lots of bone. And when you are dealing with a fracture, if there is much more bone loss, then you have to put more thicker plates, which is not desired. Chances of infection, chances of malalignment, non-union will be increasing. Are you getting it?
Jabrata, is it clear?
Now we have a DCP plate.
Yes, sir.
We have the recon plate, and we have the, I showed it this to you. I wanted to show you the recon, how does the plate looks like. This is a universal fracture plate. This is called, see the corrugations, see these things, indentations. This plate looks like this. This is called a universal fracture plate. Remember these things, because in the next examination I'll be giving the pictures of these plates, and I'll be asking you what plate is this. So you have to, by seeing it, you have to answer it. This is a universal fracture plate. It looks like just indentations. The recon plate is also somewhat like this. I'll show you the original photograph later on. Let me come up with the slides, because we have crossed lots of time. We used lots of time. It's already 8:30 out here. But recon plate is thicker. It's quite thick. It can bear the load. So we give recon plates only into areas. Suppose in this area we have a comminuted fracture, we'll give a recon plate because it has to bear the load. And these are called a mini plate. These smaller plates are called a mini plates. This is another DCP. This is called a dynamic compression plates. So, and now another very kind of fracture that happens in the angle is this angular fracture. See the fracture, how it happens. There is a sagittal split in an angle. It goes in an angle vertically and in an angle. There are a lot of comminuted fragments. What will you do in these cases? Straight away put a reconstruction plate, because reconstruction plate around 2.5. This is the parameter of the thickness of the plate. It's very important. Whereas the I'll tell you the mini plates about. I need to tell you the mini plates. I skipped that thing, but I'll tell you the last of the slide. And out here, can you see? What can you see out here? There is a lag screw. Since it is a vertical, sagittably it has split, a lag screw is placed. And what is the rule of lag screw? The screw should always pass vertically through the fracture line. The lag screw should pass vertically through the fracture line. Lag screw is a specialized type of screw which can compress this fragment. As you screw it down, it will bring the fractures closer. This is the property of lag screw. But you have to do some research, because I don't have that much time to explain all what is lag screw. So I have the PPT ready, but it will take a lot of time. If you have a comminuted fracture in the ascending part of the ramus, what you can do initially, put small plates and screws and fix the various fragments. First step is fix the small fragments with small plates and small screws. After this is done, then you put a universal fracture UFP, universal fracture plate. Then only you put a universal plate. What will the profile of this plate? 2.4. What is the profile of the recon plate? Profile of recon plate? Anybody remembering it? I just told you. Good. Jabroto. Okay. I'll just show you the plates. I'm just pushing it back. Just bear with me. Now these are the plates which you use. This is called the adaptation plate. It's very thin sort of plate. You can see the gauge in millimeters, the thickness in millimeters. 1, 1.3, 1.52. This is that. Then we have various L plates. Then there are Y plates. Then there are T plates. There are H plates. Various small mini plates. They are of the gauge. Can you see the gauge? These are all made out of titanium. All plates. Because nowadays titanium is used. What is the justification that we use titanium, not stainless steel? We do not use stainless steel, but we use titanium. Why? Remember, stainless steel, I told you chromium. People, 20% of the population are allergic to chromium. Second, corrosion. Third, fairly compatible. What about titanium? Titanium is very inert. Biocompatible. Toxicity is lesser toxicity. Why? Rather nil. Lesser toxicity. Why it's nil? Because titanium does not get exchanged when it is in cell body. Iron can get exchanged. Iron in stainless steel can get exchanged. So this is the reason. And the most important thing, everybody should know this, that if I put a titanium plate, since it is so much biocompatible, it will stay in the body it will stay for longer periods of time, maybe whole life. So there is no need for another surgery to take it out. We don't need another surgery to take out with titanium plates. But whereas in stainless steel plates, we need to take them out after a span of 2 years. Now these are many plates. Actually, there can be continuously. There can be like this. There can be with gaps. Certain 3 holes are here, 3 holes are here. Various types of media plates. Now what do you see? These are dynamic compression plates. These are dynamic compression plates. Can you see this? Can you see this thing? What is so striking about it? See, it's not fully round. See, there are obstructions here. Why? Because, as I told you, the idea behind the dynamic compression plate is this. Suppose if this is the plate surface and we are trying to push a screw through it. Sorry. I'm trying to push a screw through it. What happens? I will not pass the screw through the center of this. Suppose I'm not exactly in the center in TCPs. I'll not pass through this exactly center. I'll pass it through little eccentrically. That is eccentrically. Suppose the fracture is towards this side. I'll put it towards the fracture side eccentrically, not in the center, light little bit. Because as you tighten it, as it goes down, it will push this fragment, the fracture fragment below, forward. As a result, there will be a compression. I showed it to you. There will be a fracture fragment will get closer and it will compress, and they'll compress very well. This is the advantage of a DCP. But do not use compression in all cases. Like comminuted fracture, do not use it. Avoid using DCPs. So these are all the DCP plates. These are universal fracture plates. Now see, this is the universal fracture plate. And this is called a. Can anyone tell me?
Anyone?
This is also universal fracture plate. The only thing that they have the ramal part. They were molded into the shape of the mandible, angle of the mandible. Anyway, these are not very strong plates. They are not strong. They are not strong. They have the chances of fracture, high chances of fractures. These are recon plates. These are quite strong. Can you see the thickness here? You can see the thickness out here. It's quite strong. And there are two types. One is the very simple type of screw can be used. Another type of screw that can be used is called the locking screw. Can you see these threads? Because this screw is this one, and this screw is this one. That is, inside the plate, it is going to lock because the thread are made for that. It has to lock inside the plate. Locking screw are better. They hold the fracture fragments better. This is another recon plate which is quite big, 40. This is called the top plate. And very unique thing about this is also a locking screw. This is also a locking screw. What you have to do is you have to initially use screw, because these plates are so fat that you need to use lot of torque to turn this. You need lot of torque to turn this screw. So the initial hole is quite big, and so you can use larger diameter screwdriver to drill it in. As you can see it here, you drilled in. After that is drilled in, you put this screw inside this. So as you put this screw, since there is a gap out here, this gap happens to flare towards outside. As they flare towards the outside, it is going to catch up in this area. It is catch up this area. Can you see it is flaring outside as you are tightening this screw? So obviously it becomes locking. It becomes locked onto the plate. That is the purpose of the locking screw. So this is another modification called the Thorpe recon plates. So this is just a recap of screw, a fracture, the simple screw we can see. We can see a locking screw. Can you see the threads? This is the recon screw, and this is the Thorpe screw. This is used in many plates, even in larger plates also, universal plates also. But unilock, this is a locking thing. These screws are very good because they lock with the plates. But remember, in till the diameter of 20, you actually all the craniofacial screws by default can be used as a locking screw. All the craniofacial screws by default can be used as a locking screw. Remember it, because when you drill it in, there are no flutes out. These are the same flutes which will present. That will be because these plates are soft. Because till the profile, because from 1 millimeter to 2 millimeter, these profile plates are very soft, and as you compress this screw inside, it can go and settle well inside. This is very important thing. So, what do you think? This is happening. Do you know the answer of this question? Do you know what is the happiest hour?
Anyone, can you just tell?
Okay, that's all from my side. I went little fast. The later part of the fracture mandible. We can have any some other. Continuously, we'll be having all the seminars later on also. So we'll be continuing maybe later, maybe after 2 months, 3 months with the same seminar, and I'll be dividing mandible fracture into 2 parts. And at that time, if you have any queries, and those queries, and if you have any doubts, those queries will also be answered. And in the meantime, even if you have queries, do happen to tell Sayantan, and I'll respond it back from here, or I might mail you back. That is over for me, and now it's time that I just only the little part is left. There's a condylar fracture. This will be dealt with by Dr. Mukesh Choudhury, and I'll be handing it over. And I hope it's done very fast, because I know you all are hungry by now.
Thank you, sir. So over to Dr. Mukesh, sir.
What I'm telling you, Sayantan,
Yes, sir.
Dr. Choudhury will be continuing. Oh, you can use this. Someone was having some problem with answering a sheet. Someone didn't answer.
Yes, sir. That has been shorted, sir. Yes,
Okay, fine.
Yes, sir.
That's great. So if you have any questions, you can ask me. You can turn it. That's it.
Yes, like if anyone has any questions, that you can write in the comment section.
Okay, you can sit here. Just... What did you say? Sayantan, please check the mic with Dr. Choudhury.
Yes, sir.
It's working.
Hello, Dr. Mukesh, sir. Like I'm audible to you.
Hello. Am I audible to you?
No, sir. Your voice is coming a bit faint. No, sir. There is a lot of echo, sir.
Okay, now.
Yes, now, sir, it's okay.
What's going on?
Yes, yes. Now, sir, it's okay.
Starting mandibular condylar fracture.
Will you see my screen? Will you see my screen?
Yes, sir, the screen is visible.
Okay. So let's start with mandibular condyle fracture.
Yes, sir, yes, sir.
Okay. As we know that as Saras talked about the entire mandibular fracture, various biomechanics. So I'll be telling you briefly about mandibular condyle fracture. As you see on the screen, after pointer icon. The pointer, you can see the percentage of condyle fracture, which is around 20 to 26%.
Sir, the sound is not coming, sir.
Hello.
Yes, sir, now it's
Hello.
yes, sir, now it's left.
So as we can see,
So there is a lot of echo. So I think, sir, there are two devices near to each other from which you have logged in. That's why, sir, there is a lots of echo.
No, sir. If you are on a microphone, sir, I think the only laptop can suffice that. Sir, there is no need to use the microphone. The microphone is creating the problem, sir. If you want, you can use only the laptop only. First
Okay. Okay, fine.
Yes.
मेरा laptop use करो.
audible?
You present it from my side.
So this is the task.
You must speak. Say it loud, say it loud.
Hello.
Yes, sir, it's all fine, sir.
Audible, right? Okay.
Yes.
Okay, we'll start. Okay. Just a second. Just a second.
Which version?
Sorry.
2023. Where are you? 2020. Someone ask question.
Yes, sir.
Can you summarize? Okay, there's a bit of glitch right now. Can you summarize what about little bit of plates? Can anyone say something about plates? Mini plates, DCPs?
Anyone?
In the comment section.
Yes. Anyone?
And speak. Someone unmute and speak.
Someone can unmute and speak.
Jabroto, I think if you want, you can just turn on your mic and speak.
Laptop. Well, update the laptop.
Sir, mini plates are basically the plates which are having the thickness of 0.8 to 0.9 millimeter to up to 2 millimeter. and sir, the width is nearly 6 millimeter,
Right.
and sir, it has basically two hole diameters. One is outer and one is inner, sir. The outer hole is of 2.8 millimeter and the inner hole is of 2.1 millimeter, sir. And sir, it can be with only holes, and in some cases we can have the steel gaps between them.
Right. Right. That's good. That's fine.
Thank you, Joy.
What is so characteristic of a DCP?
Okay, anyone? If anyone want to answer, just turn on your mic and speak.
I can. I want to ask some of the person which whom I can see on my screen. I can see that is Hiba Akhtar.
Okay, Eva, can you hear me? Please turn on your mic.
What is the profile size of a DCP? Or you tell me the profile size of recon plate. I give you three options: 1.4, 2.4, 2.7. I can see Bhumika Agarwal. If Hiba is not answering, then Bhumika Agarwal.
Bhumika, can you hear me? If you want to answer, then write yes.
It doesn't matter if you can't answer, but at least you should try to answer. It doesn't matter if you are all time you have to write. It may not be. No answer? Okay. So Aniket, please unmute your mic and answer me one question. What is the profile size of a DCP, dynamic compression plate? I give you three options: 1.4, 2.4, 2.7.
Can you hear us, sir? Hello, am I audible?
Yes,
Hello?
I think, sir, like Shaikat sir, I think you and Mukesh are like sitting at very close proximity. That's why, sir, there is a lots of echo.
Hello, am I audible?
Yes, sir, now you are audible. Now it's fine, sir.
Volume?
Hello, am I audible? If I'm
Yes,
audible, kindly mention in the chat section.
Yes, sir, you are audible, sir. It's clear, sir.
Okay, we're back with the mandibular condyle fracture. As I was saying that the condyle is around 20 to 26%. It has an estimate of occurring, and at the same time, symphysis has around symphysis and parasymphysis has around 30 to 50%, which is quite similar. That means these two kind of fracture, condylar as well as symphysis fracture, they go hand in hand. It is very common scenario to find a patient with condylar fracture to have a symphysis or a parasymphysis fracture. Moving on to next slide. That what is broken needs repair. As you can see, it needs to be repaired because broken part looks aesthetically bad. Functionally also it has to be stable. Overall, what is broken, it needs to be repaired. Now we'll start with, very briefly, we'll start to know more about the condyle. Since we're talking about condylar fracture, we want to know more about the condyle and the head, neck, subcondyle. So what is the role of a condylar fracture? Basically, we all know it forms a very important part. We have been studying since first year, that is it forms a part of the TMJ, that is the temporomandibular joint, also known as gangliono-arthroidal joint. What does gangliomos mean? It means a hinge-like action, or the initial translation that we see once the patient opens the mouth, and then we have translation action, that is the arthroidal joint. The other part is that it also has a very important role, that is, it is a major growth center for mandible. You know that it is an important constituent of the TMJ, so it also is involved in TMDs, that is the temporomandibular joint disorders. Structure basically, also we have to know more about the surgical anatomy. So we start briefly getting to know more about the structure. That is, first we'll talk about the head. So the head, as you can see, it is shaped like a knuckle, and we see on the screen the head is in all the aspects. That is, we see in the anterior as well as posterior, medial and lateral aspect. So having a brief osteology class right now. As you can see, the medial pole, there are two poles basically, medial and lateral pole. Medial pole is slightly rounded and extends from the main plane of the ramus, whereas lateral pole, it's mostly roughened and it is blunt. Apart from that, we also have an anterior and posterior surface. The condyle head, basically mediolaterally it is around 15 to 20 millimeters, and anterior posteriorly it is around 8 to 10 millimeters. That's a very important thing, that is, it has a fibrous layer which is thin on the posterior aspect and is thick on the anterior aspect over the convexity. Basically, as you can see in the anterior aspect, specifically in this region, there is the attachment of the anterior superior head, also known as fovea pterygoid fovea. So as the muscle head basically converges, it forms. So there is a fibrous layer before attaching to the periosteum of the bone. Next, it is elliptical in shape. Long axis angled backwards between 15 to 33 degrees to frontal plane. You can see in the diagram over here. This is the frontal plane, and this is the condylar head. Allowing long axis, I suppose it should be like this, but it is not like that. The long axis is actually posterior medial. This is a very important discussion, that is, the long axis of the condyle is not posterior only, it is posterior medial. If we draw these lines, if we trace these lines backwards, we'll end up meeting the point just in front of the foramen magnum, where the anterior ligament of the foramen magnum lies, point known as Bayesian. At this region, it forms an angle of 145 to 160 degrees. That is, it is mostly an obtuse angle here and an acutely sharp bend from the medial pole of the condyle. Now we start with the neck. The neck is flattened from before backwards. It's mostly a flattened structure, you can see. And there's a lot of ridges on it. Posteriorly it is convex, anteriorly it is concave, and it has a point, as I told you, for the attachment of the lateral pterygoid muscle. There's a depression on the anterior surface, which is known as the pterygoid fovea, right at this point. We also need to know the surrounding structures. So we discussed about the condylar head, the neck. Now we'll discuss about the surrounding structure. The most important surrounding structure or the adjoining structure that we'll talk about is the temporomandibular joint. So the symbol diagram we saw previously, let's discuss about this diagram. This entire part forms the temporomandibular joint. This is the zygomatic arch. This is the anterior tubercle. This is an articular eminence. So this is the glenoid fossa. So anteriorly the glenoid fossa is bounded by articular eminence, posteriorly by the post-glenoid tubercle. This is a tubercle, this is not an eminence. Rather, this is an eminence. How is the eminence basically in three-dimensional? We'll also talk about that. This is condyle. This is the styloid process. This is the tympanic part of the temporal bone, mastoid process, and this is the subcondylar tubercle with the tubercle over here. We'll talk more about it later on. The next structure, the most important structure which actually we need to know are the ligaments. There are basically three functional ligaments and two accessory ligaments. Three functional ligaments are collateral ligament, capsular ligament, and the temporomandibular ligament. Accessory ligaments don't have a very specific role in the condylar function, but overall mandibular function and mandibular movement is concerned, they have a additional role to the main functional ligaments. So we start with the collateral ligament. That is, you just have to look at this picture. So this is the disc, whereas this is the condylar head. So these ligaments, these two ligaments, which are actually attached to the edges or the borders of the disc, they are the collateral ligaments. There are two types, obviously one has to be medial and the other has to be lateral. So medial discal ligament and this is the lateral discal ligament. So what is the main role? Obviously the condylar head lies onto this disc. So obviously when this ligament binds the condylar head to the disc, obviously it restricts movement of the disc away from the condyle. Next is also this is the ligament which helps or which actually functions in the hinging movement of the TMJ, giving it the gangliono-arthroidal name. The ganglion is part of the gangliono-arthroidal. Next is the capsular ligament. It actually acts like a blanket. It surrounds the entire TMJ. It basically it houses the synovial fluid inside. It acts to resist any medial, lateral or inferior forces to separate or dislocate the articular surface. That means this articular surface will not be dislocated. The mandible does not go lateral, right lateral. If you get a blow on the chin, the mandible does not go medially because there are a lot of capsular ligamentary support. Next, also important is the proprioceptive feedback that this ligament also provides because it is well innervated. Next up is the temporomandibular ligament. This ligament is also very important. It has two important parts. It has an outer, as you can see, an oblique outer portion and two inner horizontal portion. Obviously, as you can see, it is attached one side to the zygomatic bone, on the other side the mandibular condylar neck, So the main function is it limits normal rotational opening movement. When you open your mouth, there's a particular point where the opening stops. Beyond that, this strenuous is because of this particular ligament, the outer oblique portion of the TM ligament, temporomandibular ligament. The inner horizontal basically limits posterior movement of the condyle as well as the disc. So when you open the mouth, when you close the mouth, the condyle doesn't ride back into your skull. It's because of this ligamentary support as well as other bony restrictions. Spinomandibular ligament doesn't have much significance in the biological mechanism of the joint, but we have to know it. So it's because when the entire mandible moves, the condyle also moves. Next is the stylomandibular ligament. Also, it has a supportive role to the condylar function. Next up is the glenoid fossa. As you can see, we have on this diagram, a lot of tracings has been done. This is basically a condylar tracing that I've done. On both sides, you can see an arc-shaped rim. One is the lateral rim, the medial rim. Obviously, this is the lateral side. Let's orient ourselves. This is the medial side. This is the zygomatic arch. And so this is the glenoid fossa. Posteriorly to it lies the retrotympanic fissure marked in B. Basically, it is the fissure through which the chordotympanic branch or the facial nerve it joins the lingual nerve. A is obviously the post-glenoid tubercle. Somewhere here we have the articular eminence, the tubercle of the articular eminence. This is number 2. It's the transverse ridge of the articular eminence. Again, we have the same picture over here. This is the articular eminence, and through it, medially, we have a ridge, which is the transverse ridge. It has 2 slopes. This is very important surgically, and through a lot of other pathological scenarios that we'll see. We see usually, that is, it has a descending slope and an ascending slope. Usually in cases where there is, mostly in case of TMJ arthritis, this particular descending, this particular ascending slope wears out, resulting in frequent subluxation of the condyle. Very important muscle, lateral pterygoid muscle. We all know where it is attached and everything. We'll just talk about blood supply to the head of the condyle. Since we are concerned about condyle, the most important supply comes through inferior alveolar artery. It's again a tracing. So this is the artery which supplies intraosseously to the inferior alveolar, to the condyle. Other than that, maxillary artery is the main branch, and other important branches, not additional branches, are masseteric artery and external pterygoid artery. To the neck is again the intramedullary ascending artery from the inferior alveolar artery, which is inside the medulla. And there is some direct nutrient branch and pterygoid osteomuscular branches as well. Innervation is through auriculotemporal nerve, the articular branch, and additional innervations are through deep temporal and masseteric nerves. What are the causes of condylar fracture? Very, very simple. Occupational injury, fall injury, sport, road traffic, RTA, assault. Okay, what is this? These are basically guards or other guardsmen. So let's focus on this particular sixth guard in the center. What if he starts falling down? He'll end up hitting his chin like this. So this particular fracture is known as guardsman fracture, where there is 2 components additional to the condylar fracture, either a parasymphysis or a symphysis. Other concomitant injuries like facial nerve injury, C-spine injury, displacement of condyle into middle cranial fossa, and injuries to the external auditory canal. Classification, just 2 classifications we will be discussing. One is Rose and Kelly's. Why? Because sometimes we need to discuss about how high or condylar or low condylar the fracture is. High condylar means it is inside the capsule, something which is not needed, mostly doesn't require any surgical intervention, which we'll talk about later on. And extracapsular, then is the obviously intracapsular has two components, which is involving the articular surface, and the other one which is not involving the articular surface. Obviously it has to go above or through the neck, condylar neck. And there are other injuries, condylar fractures, like the ones involving capsule, ligament and meniscus, and like the adjacent bones, for example zygomatic bone, any other bone which is nearby. This is very important classification, Lindahl's classification, which will be much more into use clinically. That is, let's first look at this picture. That is, in this case, there is no fracture at all. Here we see a fracture, but we don't see any displacement. So we have to be clear about three important things. What is displacement, what is dislocation, and what is deviation. Displacement basically means that normal, we don't see over here. Basically it also includes the disc, the articular disc component also, whether the articular disc is displaced from its main position or not. Basically we have to understand that displacement and dislocation are very close to each other. If the component is still in the glenoid fossa, it is not displaced, and if it is totally out, obviously we know it is dislocated. So we see no displacement over here. Deviation basically is deviation through the long axis of the entire ramus. So there is no deviation, obviously slight deviation. There's obvious displacement, as you can see. It is totally, it's not entirely out, but it is out. There is deviation as well as dislocation. It has been dislocated out of the condyle, is deviated as well. Now this is displacement. It's totally displaced from its position, and sometimes this fragment also can override medially or laterally. This override is known as telescoping. Kindly refer to this term known as telescoping, because this is very important. So medial override mostly is because of the lateral pterygoid pull. What is the biomechanics of condylar fracture? So condylar fracture, basically we refer to something called as hunting bow concept. It is basically, it is that it's like a condyle mandible. Entire mandible is like a hunting bow. Strongest is in the symphysis. So when we hit a blow here, this part gets little bit of the impact, whereas maximum impact is getting transferred. More tension area are the condyle, because condyle has no place to move. It gets trapped in the glenoid fossa. So therefore, this biomechanics of condylar fracture, the concept is hunting's bow concept. These are the things we have to see clinically when we examine the patient. That is, on inspection, extraorally and intraorally. Extraorally, what are the things we'll see? Obviously, when there is an injury, there has to be swelling. There will be some hemorrhage from the ear on that side. There could also be inner bleeding from the external auditory canal. There could be middle ear hemorrhage or CSF autoria, as you can see over here. Hematoma on the involved site. Ecchymosis, obviously, like over here. This sign is known as battle sign, which we all should know. And obviously, when the condyle, which is palpable, if that condyle, mostly during the medial override, when the condyle moves medially, we will see a characteristic hollow over the region of condylar head. If intraorally, this is very important. Intraorally, how to identify, we'll talk about it later on the next slide. So, what do you need for palpation? What do you need to palpate? You need to palpate over the tenderness of the condylar area, how tender it is, whether the mandibular movements are restricted or not, whether there is proper protrusion, whether there is proper lateral excursions, and to determine the displacement of the condylar head, whether it is displaced or not. This is very important, as I was talking about telescoping of fractured fragment. 4 scenarios we have over here. One is the effusion or hemarthrosis. unilateral fracture dislocation, bilateral fracture dislocation, and bilateral dislocation. First, effusion or hemarthrosis. Whenever there is an injury to the vessels in this region, there obviously will have an hemarthrosis and effusion from the synovial fluid and extraction, etc. So this particular area will actually create a pressure, because this particular area, usually bounded by the capsular ligament, forms an enclosed cavity in which it basically causes the entire mandible on this right side, to move out. So there will be a posterior open bite ipsilateral to the injury site, and midline to the contralateral side. The midline will be shifted towards the contralateral side. Next is the unilateral fracture dislocation. That is obviously this is called telescoping. Telescoping basically means compaction, or actually compression or shortening of that particular site of the that particular site. So as you can see on the right side, there is total medial override as well as dislocation of the condyle, not only head but the entire neck also. So there is premature posterior bite on this side. These are the things. These are the pearls we need to see clinically. So we see one side on the condylar part. This is basically, we have to guess. What we see is we see the occlusion and we see the midline. Again, bilateral, when there's bilateral fracture, there's anterior open bite, posterior gagging, and something called a pseudo prognatism. That is basically when there's bilateral dislocation, the entire thing is out, so they will never occlude. There will be also there will be open bite, and there will be pseudo prognatism. There is imaging. We see in the OPG both the sides. PA view mandible. 3D is the CT is the gold standard for any imaging that's related to maxillofacial trauma. Out of all the CT views, the coronal view is the most appreciable for condylar fractures, subcondylar or condylar fractures. This is the sagittal view. The axial view also you can appreciate. The goals of therapy: primarily stable occlusion. We have to restore the interincisal opening, means we have to restore the occlusion. Full range of mandibular excursive movements have to be there. Functionality has to be rehabilitated. Deviation has to be minimized. Has to be relieved from pain. Obviously, pain. Patient cannot live entire life with pain. And obviously, there has to be avoided any internal derangements of the TMJ, because you fix the fracture, but you land up with any TMDs, that is temporomandibular joint disorders. Lifelong, the patient will come back to you with problems. Next is avoid any growth disturbance, especially in case of pediatric patients. 3 modes of treatment: conservative, functional, and surgical. What is conservative? Basically, you rest and immobilize by intermaxillary fixation. That is what, in plain and simple terms. Why do we do it? Just to allow muscle spasms and telescoping to settle down. Also, inflammation, edema, all this to settle down. Duration, usually in unilateral fracture, 7 to 10 days. Bilateral fracture with an anterior open bite, posterior gagging, 4 weeks. But usually in all our clinical cases, we've seen that longer you keep, the better it is. So usually 3 to 4 weeks is This is functional. What is functional? Basically, allow a little bit of movement, that is active movement, just to reduce this risk of ankylosis. So with the help of class 2 light elastics, which is to be worn for about 24 hours a day till the occlusion normalizes. And you have to review after every 7 days till the occlusion is achieved. Every 7 days you call the patient and you check. Next is functional exercises. All these functional exercises: maximal mouth opening, right lateral excursion, left protrusive. Just a second. And why do we do it? Active movement will prevent bony union. So these are the parameters we have to look after. The IID should be more than 40 mm. Only then we can go for functional activities, functional exercises. If the lateral excursion is more than 10 mm, only then. If the protrusion is only more than 12 mm, then go for it. Non-surgical management, that is close reduction indications, very simple. Obviously, non-displaced incomplete fractures, go for it. Intercapsular fractures inside the capsule, high up, go for close reduction. In children, always indicated. And in those cases where you can reproduce the occlusion by simple manipulation like drop back technique, even in those cases we have to avoid. And if there is a medical injury or illness which will need an extended GA, we also is indicated, that is the close reduction is indicated. The advantages: one is very safe, basically don't do anything, don't you very minimal intervention, surgical intervention. Then there is no injury to nerves and vessels, you don't open up, no facial nerve injury, nothing, no chance of infection, scarring, any post-op complication, no toe jump injury. And what are the disadvantages? Basically, the periodontal tissue and oromucosa injury will happen, hygiene will be poor, nutrition will be imbalanced. Basically, mouth is shut, so he'll be having through nasogastric tube. So, on a very the nutrition basically hampers mostly. And if there is any growth disorder, mostly occurs, and then obviously due to that facial asymmetry also happens. Then what is close reduction? Basically, it is again, the teeth are brought in normal occlusion followed by maxillomandibular or maxillary fixation. Why do we do it? Because early immobilization will minimize the risk of fibrous and bony TMJ ankylosis. How do we do it? These are the various ways: through arch bars, through cap splints, gunning splints. We'll look into that. So these are the arch bars. The most important thing that you should take from here is, we all know one arch bar, particular arch bar we get in market also, and that is quite mostly common, is the Eric arch bar. Other than that, the wiring techniques are very important. Essex, Gilmer's, Residence, Stout's multiple loop, circummandibular wiring, IMF screws, circumzygomatic wiring, and gunning splints, as sir had already discussed. Cap splints are given, bonded brackets are also given. Surgery, obviously what we do is open reduction and internal fixation. Absolute indication: when fracture is dislocated into the middle cranial fossa, obviously we need to go for it. Impossibility of obtaining adequate occlusion by close reduction, then we have to go for ORF. When the fragment is basically laterally dislocated, we have to bring it back and we have to reduce and we have to fix it. Or there is an invasion by a foreign body like a gunshot injury, we have to go for it. This is basically once we follow this Sayantan criteria. What is relative indication? That is, in case of initialus patient, bilateral condylar fracture, we cannot go for this thing. Mostly we cannot go for close reduction, we will go for ORF. Or when splinting is impossible, I tend to go for this. And when splinting is non-recommended in case of unilateral bicondylar fractures, specifically for medical reasons like there is seizure disorders, psychiatric problems, alcoholisms, and so on and so forth. Any comminuted mid-face fractures, associated condylar fracture, have to go for ORF. And if there is any associated nathological problem like retrognathia or prognathism, open bite, loss of multiple teeth, unstable occlusion, in all those cases also there is need to be applicated. AAOMS has given some guidelines. Basically, like reduce all the indications into few indications like physical evidence of fracture. Obviously, you get it through physical evidence, you get it through your inspection, calculation, and all that. Imaging also confirms fracture. Malocclusion is there. Mandibular dysfunction happens. All the functions are not happening properly. Abnormal jaw relation. There is foreign body presence. Laceration or hemorrhage into the external auditory mucus. When you have to open, you also go for ORIF. Hemotympanum is there. CSF autoria, diffusion, and hemathrosis. Again, I'll start with the contraindication when we don't do. When it is contraindicated, it's basically again condylar head fracture. When the ligamentous attachments usually are involved, when there's a single fragment, or it is that is comminuted, or the medial pole has been totally gone medially. Medical illness is there, which basically stops from going into the GA, and occlusion is good, pain is minimum, and mandibular movement is also acceptable. We have to stop. We do have to consider for the ORIF. And what are the relative contraindications? Basically, it's very simpler. If the method is very simpler, condylar neck fracture, which we cannot, and if there is no obtained neurological status. Surgical approaches to condylar and subcondylar fracture. This is a very important one. I'll just talk about, since I'm running out of time and I've also prepared that ways only, I'll only talk about submandibular approach and the pre-auricular approach. So let's look at this diagram. Basically, first one is the submandibular approach. These are the various areas we can reach, we can expose to a submandibular approach. Then comes the retromandibular approach. You can see other retroparotid till here, transparotid till the ramus, preauricular basically till the subcondyle, and facelift again here. Let's start with submandibular residuum approach. Very briefly, let's try to understand what is going on. First is we need to expose. So corner of the mouth and lower lip are exposed anteriorly in the entire ear posteriorly. We need to expose the entire one side of the neck. Then we give an incision over the neck skin creases around 1.5 to 2 centimeters below the inferior border of the mandible. Somewhere here we mark the incision and we give the incision. And when we incise, the initial depth has to be till the depth of platysma without undermining. Next is we have to go subplatysmally. That is, we dissect the platysma. Then from platysma to pterygomasteric sling we go. And finally we reach the bone. And we have to suture also accordingly. We fix and suture accordingly. First the pterygomasteric sling, platysma, subcutaneous tissue, and the skin. Only the skin is done with non-resorbable sutures. Preauricular approach, very important. To access and treat, obviously you can see here, to access and treat, mostly done for many KMG pathologies. For the mandibular condylar head and neck region. And the most important is the knowledge of the neurovascular structure. That is the branches of facial nerves have a high chance of being involved in this incision as well as dissection, or due to the pull and pull post operative events also can result in facial weakness. So the important vessel that we have to take care is the superficial temporal artery and vein, which are frequently encountered. Skin incision is given in the pre-auricular skin crease. Various preauricular incision types: Blair's inverted hockey stick incision, endaural incision, Dingman's incision, Homa's angulated incision, Popovich and Crane incision, which was basically
which is basically a modified version of the alkyl Bramley. Right here we can see. When you don't need that much of exposure, we go for Popovich and Crane incision. So how do we carry out the incision? The incision is carried out through the skin and the subcutaneous tissue. The main goal should be to locate the temporalis fascia, which is basically glistening white. So first we have to reach that, and the incision should be at the depth to reach the temporalis fascia. After that, we incise the temporalis fascia. That is, we have to make an oblique incision. A horizontal incision could be detrimental in damaging the frontal branch of the facial nerve, because this is in quite a close proximity towards our surgical field. Let's understand the layers very quickly. That is, where does the frontal branch of the facial nerve basically lie during the dissection? So right at this region, you can see the frontal branch of the facial nerve. That is, it lies below the temporopalatal fascia. That is the superficial temporalis fascia that we said, and in between that and the temporalis fascia. So at this point, it divides into an anterior division, superficial and deeper layers. So right at this particular point, you can see we put our instrument. So basically, this entire thing is out of the surgical manipulation. There are certain things we need to know, the certain dimensions we take care during the surgical planning. Where exactly the facial nerve, this is the main facial nerve trunk. It bifurcates at this level, about 3.5 centimeters below the external auditory meatus, into the temporofacial and cervicofacial branches, ramize, and then again it divides into 3 branches, out of which this is the frontal branch, which again is the distance of almost around 1.5 to 2.5 centimeters from the superior edge of the external auditory meatus, the bony edge of the external auditory meatus. So once we've made an incision, then we'll dissect with down capsule, and then we'll go beneath the superficial layer of temporalis fascia and chip off the periosteum of the zygomatic arch, which lies over here. We put a periosteal elevator, and then in this way we skip the frontal branch. So we then expose the capsule, the blanket. We can give an incision if the surgery is indicated. Mostly it's not indicated. And then finally we'll close it up. Capsule first, then the fascia, the subcutaneous tissue, and the skin. What are the complications? Most important complication is malocclusion. Obviously it happens because of improper treatment, and in older patients more than 50 years of age who already have a pre-existing lock-in occlusion and definitive wear facets, or in cases where the patients have prolonged hospitalizations. Any iatrogenic injury like transient facial nerve weakness, that means 15% of patients experience transient facial nerve weakness. Chronic pain, that is in those cases which are managed through closed reduction. Mandibular hypomobility, when the physiotherapy is delayed, or the patient is subjected to longer MMF, or the patient, or basically the children who had suffered high energy injuries, and through which capsule was disrupted and the condyle was popped out. In those cases also we have mandibular hypomobility. Ankylosis, then severe meniscal disruption with inappropriate physiotherapy, when the mandible is widened, mostly has a lateral displacement. Asymmetry seen in 25% of all patients suffering from condylar fracture, could be hypoplasia or hyperplasia. In adult, the percentage increases double. Dysfunction or degeneration, that means even TMJ joint also is more susceptible to arthritis. Risk factors increases with age when the condyle is displaced. Longer period of intermaxillary fixation, and hypomobility is secondary to capsular or meniscal injuries. And condyle may also get resolved because of if the blood supply is denuded or there is non-anatomic reduction. So I'm completing my lecture. Thank you all.
Thank you, sir, for such a wonderful lecture. Thank you all for staying so long and patiently for such a wonderful session. I hope Choudhury and Bhumika, I hope you like the session very much. So meet you all in the next session, that is coming Friday, with the next session of our webinar. Till then, goodbye. Thank you, sir. Thank you all.